my thought is that I'd like to go through my slides, and I can certainly pause to answer any clarifying questions. But because we're recording these, anything that's like kind of a more kind of clinically oriented question, I figured I'd save those all for the end so that then we could kind of like turn the recording off and have some time to chat through any more kind of in-depth questions. So that's my intention for today. So what I'm going to do is share my slides. So let me set that up real quick here. All right, everybody can see those all right? Okay. Let me see. Okay, great. So yes, it's great to see everybody, and I can just start by giving a little bit of an overview of what we're going to be talking about today. So as my title slide here suggests, we're going to be talking about actually a topic that is very near and dear to me. This is work I really enjoy doing, which is working with clients who have chronic emotion dysregulation. And I'll talk in a little bit about what I mean by that. But really the focus of today is not going to be on sort of the interventions or like what you might actually do in work with these clients, but more about the frame of treatment. So as I have noted on our overview here, I'm going to talk about assessment. So sort of how you might notice, okay, early on in treatment, this seems like a client who might fall into this category. And then treatment planning. So components that you're going to potentially consider when you're creating a sort of well-integrated, holistic treatment plan for working with these clients. And then finally, some just anticipating of difficulties. So, with this long-term work, sometimes there are common concerns that come up about things like risk management and boundary setting. Those will be the two things that I'll focus on in the conversation today. And as I said, if you have any clarifying questions as I'm going through the presentation, feel free to just kind of jump in, unmute yourself and let me know of those. You might be able to put them in the chat, but I don't know that I can actually see the chat. So that might, if somebody puts it in the chat, maybe Julie, if you see it, you can sort of note that. All right, so what am I talking about? So chronic emotion dysregulation, this isn't necessarily a term that I would say is kind of widespread in our field, but there are certain areas, and certainly as many of you know, I work primarily from a DBT perspective, and this is certainly a kind of DBT-ish term for what I'm going to be talking about today. But in a broader way, really what I'm referring to is clients who report longstanding and persistent history of mental health difficulties. So certainly there are going to be certain kinds of diagnoses met that we might be considering here. So things like personality disorders, major mood and depressive disorders. So these would be like kind of chronic and persistent depression, either MDD or maybe dysthymia, major mood disorders like bipolar disorder. I also find this comes up a fair amount with chronic PTSD. So people who've maybe had, especially like early childhood trauma, and then kind of sometimes it's referred to as complex PTSD or chronic PTSD. Psychotic disorders would also fall into this category, though I'll say that my presentation today is not really aimed at treatment frames for psychotic disorders, since that often calls for a little bit of a different approach, but more of these other three categories of disorders that I'm mentioning here. So one thing I would like to do before we really dive in is take on this question. And I'm not sure if people can, I think people can actually open up a chat box still. I believe if you hover over maybe the top of your screen, you may be able to find your chat box. But what would be great is to just elicit some thoughts on this question here. So what can clinicians listen for at intake that might indicate the client is experiencing chronic emotion dysregulation? And the idea here being that sometimes it's important to know kind of as early as possible when you're meeting with somebody that this is something that is relevant. So let's see, can people see their chat boxes? I'll give people a minute to just type in some ideas for how to answer this question. So really anything people might be reporting as they're coming into therapy. Great. So a few things coming in. I'll start reading them out as they arrive. So lack of joy when around others, isolation. Absolutely, Ron mentioned that. People sort of talking about loneliness. Long-term loneliness or relationship distress. Yes, reporting distress from a young age. So people who are really saying, as you ask, when did this start? And they say, I've been this way kind of as long as I can remember. Martha, yeah, the way that they describe their relationship, sometimes a chaotic description. So maybe people talking about lots of significant relationships in their lives that have been really distressing or kind of, on and again, off again, lots of conflict potentially in relationships. Hopelessness, yeah, not believing that they can change or change their emotional experiences, being told by others that they're too sensitive or their emotions are too much. Yeah, I think this is a group of clients, and I'll talk about this a bit, that often will come in with very high levels of hopelessness. And oftentimes because they have been told by other people that you're too much, I can't handle this, or sort of you're too crazy, or the way that you experience things is too intense. And that can lead to hopelessness. Problems across a lot of areas of functioning, for sure. So people who are saying, yeah, not like, oh, I'm coming in with, a particular concern about maybe work or relationships, but it seems like sort of every domain in their life is affected by their presentation. Yeah, Yoon's point. So the intensity of the client's affect during the intake, for sure. Sometimes clients who are coming in with just a lot of intensity, maybe sort of a fair amount of like lability throughout the intake. So their sort of affective presentation during the intake. Long history of relationship problems. So people who are reporting maybe attachment styles, like Julie mentions, that are avoidant or anxious. So when you're getting that caregiver history, kind of listening for, what was the security of their attachment growing up, and then also the quality of their relationships in adulthood. And another great one from McKay, so self-invalidation, insulting oneself. So a lot of clients in this kind of category we're talking about will come in with just pretty low sort of self-confidence or self-esteem, maybe a tendency to be really critical or judging of themselves. And Yoon, absolutely, history of self-harm behaviors, actually often related to McKay's point, people who might be engaging in non-suicidal self-injury, which we'll certainly talk about as well. And I'll give everybody maybe one more moment to enter things. So Hillary, yes. Let's see, hints when listening to histories of prior treatment. This is a great one. How many episodes of treatment has somebody been in? How long have they been in treatment for? Maybe often getting that sense of like, nothing ever works for me. I've tried, dozens of things and nothing works. That's, I think, a pretty common complaint. All right. This is great. I'll actually close the chat here and show everybody my sort of list, which I think has a fair amount of overlap with things that people are reporting here. So signs of long-term persistent symptom presentation. Like I was just saying, that history of unsuccessful treatment, this is common, especially people who have sought maybe lots of different, oopsie, that wasn't what I meant to do, lots of different kinds of treatment. And finding that whatever they try, they just haven't found something that works for them. And then history of chronic trauma. This one wasn't mentioned, but I imagine certainly related to things like attachment style, but also just generally kind of listening for early invalidating environments. And I'll talk more about that in a moment. This is one I like to assess for pretty systematically, is family history. So listening for maybe other family members who have major mental illness, especially in those categories that I mentioned before. I always assess for history of suicide attempts, chronic suicidal ideation, and non-suicidal self-injury. I'll talk more about this, but I really think about, this is often a group of clients who, like we were talking about, can come in very hopeless, feeling like nothing's ever going to get better for them. They've been in distress for a long time. And therefore thoughts of suicide or self-injury kind of make sense, given that context. So that's a pretty common presentation. Relatedly, perhaps patterns of reckless or self-destructive behavior. As we talked about, lots of instability in relationships, but also instability in sense of self. So this is also where you might be looking for things like work history or relationship history to just kind of get a sense of identity development. And then finally, history of persistent mood episodes or emotional distress. So these, again, are going to be clients who are reporting that they have felt this way for a really, really long time, maybe as long as they can remember. I do think that this is often just a helpful mindset to get in early on in assessment, in the sort of assessment phase of therapy, is when you realize that this is a client who's coming in with long-term, chronic emotion dysregulation. I really argue for like a flip sort of needs to switch in your mind, where it's like, okay, this isn't, sort of an episodic state of distress that we can expect therapy in particular to address quickly. This is going to be more of a long-term kind of approach to therapy. And I think it can be really important, for us as therapists to get into that mindset. And also, as I'll talk about later, for us to discuss that with clients. Sometimes people come in expecting like, oh, I should feel better in a few months, right? And certainly there might be some, and hopefully there's some reduction in distress, but kind of, full, recovery might not be possible within just a couple of months. Personally, I work from a biosocial model when I'm thinking about chronic emotion dysregulation. This is certainly the primary model in dialectical behavior therapy, but it's also really sort of trans-theoretical. And it's this idea that emotion dysregulation results from a biological vulnerability paired with some sort of a particular early environment. So that biological vulnerability can be a lot of different things. Certainly it can be genetic, for example, but it can also be sort of like in utero or early childhood impacts on the brain. So any kind of sort of basically neural difference that might predispose people to high negative affect, emotionality, and impulsivity. And also, usually when working with these clients, there's some kind of a history of an early environment that was invalidating in some way. Certainly this can be trauma, but it's also not necessarily trauma. So I really like, especially from a DBT perspective, there's some thought around kind of mismatch. So maybe a client, for example, is predisposed to sort of high intensity emotions. Parents are not, or sort of don't have the kind of emotional language to sort of help this child figure out how to regulate themselves. There's a lot of focus oftentimes on caregivers, so this doesn't necessarily have to be parents, but whoever those kind of early attachment figures are for an individual. And particular things like any tendency to invalidate emotions or improperly model appropriate expression of emotion, or reinforce emotional arousal. So, child maybe gets the attention that they require, but it's not until they're at, a kind of 10 out of 10 in the volume that they're expressing themselves. I find this model to be a really intuitive one, and therefore often really understandable to clients, and something that can just help to sort of validate what they've gone through and why they continue to experience distress in the way that they do. So at the end of the presentation today, I'm going to go through a list of some of the things that I talk about with clients, usually early on in treatment. This is one of them. So I'll often talk about diagnostically what's going on, but also just more of this kind of broader case conceptualization. People sometimes come in feeling like, gosh, I've been struggling for so long, why can't I get over this? What's wrong with me that I can't feel better or benefit from, treatments that are supposed to work for, X, Y, or Z. But helping to sort of explain to clients, look, there is sort of reason that this is very hard to overcome. And a lot of it comes from these sort of early patterns that maybe they've developed when they were quite young and that have stuck with them for a really long time. All right. So once you have made your assessment and have a sense that this is a client who's likely struggling with kind of this more chronic pattern of emotion dysregulation or mood difficulty, there are lots of things to think about when it comes to choosing a treatment. I want to just present briefly some of the levels of care that are often considered when working with these clients, just to remember that for many people, once weekly individual therapy sessions it's just not sufficient. So individual psychotherapy still is kind of in the middle here. We're doing this with people, but it's important, especially with this population, I think, to think about other options. And this is certainly not exhaustive, but some of the ones that probably we consider most frequently. Group therapy, certainly a wonderful place, especially for clients who are struggling with relationship concerns, to learn about themselves in a group context, whatever that group therapy is. Can just be a really helpful adjunct to your individual therapy. So certainly, from our DBT perspective, we're referring to a skills group, which also has the sort of wonderful content that comes with DBT skills. But again, it's also just being in that interpersonal context and finding ways to relate to other people, through that group therapy. But also, I know a lot of other therapeutic approaches might be referring these sorts of clients to things like interpersonal process groups, for example. Medication management, this is a place that oftentimes people who have been experiencing distress for a long time already have some kind of provider who's prescribing medication for them. I will say, just from my experience, and I think that a fair amount of research on this shows that oftentimes when somebody's coming in with this chronic presentation, medication may be necessary, but it isn't sufficient. So just because somebody's on medication doesn't really mean that they're going to be getting all the benefit that they can from it. I often see it as sort of like I'll talk with people about sort of building a foundation for this house that we're sort of building together. And medication might be part of what needs to be in that foundation. Like, in order to use skills, for example, having some amount of kind of support of mood through medication might be helpful, but it's also not going to be sufficient. So medication, sort of to temper expectations a little bit, that just because somebody's trying a new medication, for example, doesn't necessarily mean that they're going to get all the benefit that they want from it. I will also note, though, that within medication management, we might just think of sort of psychiatry more broadly. So there's also a lot of other very interesting biological interventions being done for mental illness right now. So things like TMS, transcranial magnetic stimulation, or deep brain stimulation, or ketamine treatments, as well as certainly some different actual medications. So, or even just things like another one I'm sort of interested in is sleep deprivation therapy is another kind of approach that's been shown to be helpful for treatment-resistant mood difficulties. So I've had an ECT, of course. I've had a number of clients who have interfaced with some of these different sorts of psychiatry interventions with actually some kind of interesting periods of success. So this is something too, this is a group of clients that I tend to be a little bit more maybe involved with their psychiatrist, consulting outside of session to see if there are any approaches that maybe they haven't tried yet that could potentially be helpful. Of course, sometimes it's important to know that you can level up the care further, and that's where you're thinking about these bottom two options, so intensive outpatient programs or inpatient programs or hospitalizations. I will say that right now, during the COVID pandemic, it can be really hard to find in-person options for this. A lot of this is now online, and Zooming all day long for an IOP, for example, might be highly distressing already for somebody who's highly distressed. So right now I'm using these a little bit more sparingly, but generally I tend to think about providing a lot of outpatient contact already in my therapy frame, but then also leveling up as needed. So sometimes needing to think about an IOP, and there's a lot of great options in Southern Maine, or sometimes inpatient hospitalizations, though those tend to be more about stabilizing, less about kind of maybe a therapeutic outcome. In terms of the therapy itself, though, I wanted to just compare a couple of treatment frames that I'm sort of most familiar with. So my training background has been in dialectical behavior therapy, DBT, and also transference-focused psychotherapy, or TFP, which is a psychodynamic approach. There are a lot of approaches out there to working with chronic emotion dysregulation. These are two that have been empirically supported and that have some sort of interesting areas of overlap, but also some real distinct areas of contrast. So I wanted to just present these two again. I'm not going to go into the sort of interventions themselves, but just more focusing on what the frame looks like so that people can really get an idea for, when someone's coming in with this long-term distress, the frame is going to look different, or sort of to be effective perhaps needs to look different than what you might think of for a more kind of episodic sort of client. So certainly in DBT, we've got the weekly individual therapy. And the focus there is we'll talk a lot in DBT about being sort of a skills coach. The therapist is a coach. The therapist is very focused on behavioral patterns, but also helping people to improve skills use that's focused on building acceptance of yourself and of your life. So there's the weekly therapy. There's also the weekly skills training group, and that is usually 90 to 120 minutes, an hour and a half to 2 hours long. So already you've got two sort of substantial contacts that this client is having with therapy, both in the group and individual. There's additionally this as-needed brief skills-focused phone coaching. So this is in the full model of DBT. Your individual therapist is also doing 5 to 10-minute phone calls. And again, this is sort of like it's a coaching call. So it's a client saying, hey, I'm trying to use X skill and I'm having trouble with it. What should I do? And the client or the therapist hops on the phone and says, oh, you tried it this way. Well, why don't you try this instead? Or maybe do this skill. So it's very involved in that way. And because it is a pretty intensive treatment, there's also this consultation group for therapists to really get the support that they need in doing this work. I took a couple quotes here from the DBT manual that I appreciate. So the therapist is, quote, a skills coach, where the group skills training leader seeks to, quote, increase clients' abilities by teaching DBT skills and eliciting practice. And then the individual therapist is seeking to, quote, manage crises and help a client to apply the skills that they're learning to replace dysfunctional behaviors. So obviously, very behaviorally oriented, as you might expect from the name. And then the other side, we've got TFP, which is, again, empirically supported even for the same population, but a very different kind of approach to the work. So in TFP, there's twice weekly individual therapy. So again, you're not, we're seeing that clients are coming in multiple times per week for some sort of therapy intervention. And the goal here is building insight into emotional and relationship patterns. And it's really based on this idea of technical neutrality, which is the therapist remaining neutral. So not saying do this, do that, which is different from DBT, where a therapist might be much more directive about kind of in particular acting with sort of skillfully. In TFP, a therapist is going to be sitting back a little bit further, creating this kind of space of neutrality, occasionally breaking neutrality, but usually it's in sort of emergency situations, but really kind of more creating this space for insight to build, and the client kind of leading their way towards behavioral change instead of the therapist saying, hey, change this behavior or change that behavior. And still, the TFP manual says oftentimes twice weekly individual therapy still might not be enough. So they're recommending, group therapy as needed, or even skills training. So sometimes a client might be in TFP, but then go, join the DBT group. Couples therapy, meeting with nutritionists or dietitians, whatever is needed, kind of based on the clinical presentation. Very different from DBT, client contact happens in session only. And this is something I'll talk about a little bit later, is just setting kind of communication boundaries. So here, the therapist is only managing out of session communications in case of emergency. Otherwise, everything is happening in session. And the idea is that this is also removing any reinforcement of therapy interfering behaviors. And there's a lot of focus in TFP on suicidality in particular. If therapist reaches out to client every time they're in crisis, it sort of reinforces potentially crisis behaviors. So I love this quote from the TFP manual just because it's so different from DBT, which is, given your history, we know that you'll be continuing to experience times of feeling upset, anxious, and suicidal. It will be your responsibility to deal with these feelings as they come up outside of session. And I really like this comparison because these are two kind of vastly different approaches to working with clients. Both of them have great empirical support, which shows that I think, and I'll say this again probably later, like a lot of it has to do with picking your theoretical model, and being deliberate about sticking to it, but knowing that there are different ways to work with these clients. So you don't have to necessarily work within there's not like one way to work with or sort of set the treatment frame, so much as it's important to be deliberate and consistent with whatever you choose. Which leads me into some of the difficulties that can come up here. So one of the biggest ones, and I think this is already sort of implied in what I put in the previous slide between the DBT and TFP approaches, is setting therapy boundaries. Basically, when are we in contact? So communication, and what does that communication entail? Here, I really, really emphasize just being so direct about your expectations, and then being really consistent with reinforcing them. So being intentional and consistent and working from a theoretical model. So outside of therapy, you can see, from the DBT perspective, there are coaching calls and there's a lot of ideas around sort of reinforcing clients reaching out to a therapist before they're at, a crisis point. So, talk to me sooner so that we can get you using the skills you need to use, instead of reaching out saying, I'm about to cut myself. What are you going to do now? So getting people to kind of be proactive in their skills use by seeking support from their therapist. Versus the TFP approach, which is, like I said, you're going to be in distress. You need to manage that yourself, essentially. Talk about it, when you come back into therapy next time. It's not like you're sort of being unhelpful or invalidating, but you're also, kind of stepping back a little bit as a therapist to sort of accept that clients are going to be in a lot of distress and will manage it how they will manage it until over time they make those changes. So I think this just shows how there's really not a right or a wrong answer here in terms of what your sort of outside of therapy communications might look like. But you have to make a deliberate choice and follow through. You also have to, I think, be really direct with how you express this to clients. So I know a lot of us have, from a sort of non-DBT perspective, maybe a spiel we might give to clients around like, hey, you might, email me or call me between sessions. My practice is not to respond to those unless it is, an emergency situation. That's a great way to very directly communicate what the boundary is. And then when potentially it gets crossed at some point, you can say like, hey, remember we talked about this. This is kind of the expectation there. But even with DBT, where we're having potentially much more outside of therapy communication, there are still boundaries. The boundary is really that whenever a client reaches out is because they're willing to use skills and they will follow through on whatever the skills recommendations are that have been made. And that they will reach out when they are kind of pre-crisis, so ready and able to use skills. So again, you're setting that boundary up front so that when it gets crossed, it probably will at some point. You can say, hey, remember that was the boundary. What happened? What made it hard to kind of follow that boundary? So again, whatever you choose, make a deliberate choice and be direct around your communication. Self-disclosure. I think this is the other kind of communication area that comes up a lot with this population, and in part because this is long-term work. So you have a lot of maybe opportunity. You might be working with a client for years, and they might learn a lot about you over time. And that, I don't think necessarily there's problem in kind of thoughtful and intentional self-disclosure, but I just think about being aware of the slippery slope. So especially since it tends to be a longer term therapy relationship, if you're sort of sharing things a lot up front, over time, if somebody just knows a lot about you. And the reason that this can be problematic is that, self-disclosure is, I think, or sort of limiting self-disclosure is a protection for the therapy relationship. Oftentimes the more that a client knows about you as a therapist, potentially the less they feel safe to share openly, because you're suddenly a person who has a lot of, they might have sort of ideas about what your beliefs or your kind of reactions might be to different things. And two, this might limit your own ability to remain objective. So I take this self-disclosure piece particularly seriously when I have a sense that it's a client I might be working with for a long time. Because again, over the course of potentially years of working with somebody, I want to kind of set my, be consistent, kind of set what my expectations are in terms of sharing about myself early, so that it doesn't become this sort of slippery slope over time. Another area of difficulty, and certainly overlapping again with kind of ethical concerns, is risk management. So when you have somebody who's been in distress for much of their life, oftentimes they will report chronic passive suicidal ideation and or engagement in non-suicidal self-injury. And non-suicidal self-injury can be a lot of different things. I tend to take a pretty inclusive definition here. So certainly, cutting, burning, hitting yourself, but also things like sort of eating disorder behavior sometimes, like restricting or binge eating, often I think can fall into this category. Really anything that somebody is doing with some part of the intention to inflict pain or discomfort. And I do think it's important to ask a lot about sort of what an SSI does for that client. So, for many people, it can be actually very regulating as much as it is painful and discomforting or uncomfortable. It can also be emotionally regulating, which is why it can be really hard to change the behavior. But either way, this means working with this population involves an assumption of some level of risk. And that's just, maybe uncomfortable sometimes as a clinician to think about kind of starting work with somebody who has this history, knowing that, this certainly is a population where risk level just is higher. Well, because of that, there are some things that I really try to set early on in the treatment to help me work with this over that course of potentially a long-term relationship with a client. So I really encourage speaking directly with your client about any suicidal thoughts and self-harm. Part of this is just an assessment phase. So I like to really be able to answer some of the questions I have on the slide here. So the why, what is prompting suicidal thinking or self-harming behavior? With self-harm, is it sort of, is it self-punishment? Is it self-regulating? Is it numbing? There's a lot of reasons that people engage in self-injury. For the suicidal thinking, oftentimes there's some amount of maybe hopelessness that's coming up and expressing in that way, or a belief that one is a burden on other people and therefore others would be better without them. And then from that, what are the triggers? What are the things that maybe lead to a worsening of that behavior? In part because I think it's so important to help clients to be able to predict this behavior for themselves, or these feelings for themselves. Some people can be so maybe unaware of what prompts it, that then they find themselves suddenly spiraling in this maybe suicidal way unexpectedly. And then they feel, oftentimes there's a lot of feelings of shame even about these thoughts, like what's so very wrong with me that I think this way. So helping people just to kind of conceptualize their own feelings or behaviors, I think can be really actually pretty regulating and sort of normalizing or validating. And of course, looking for reinforcers. Again, back to that biosocial model, that for some clients, expressing themselves at the highest volume is the only way they ever really were heard. So are there things that are potentially reinforcing that kind of self-harming behavior or those thoughts? So helping clients to understand what prompts their suicidal thinking so then they can anticipate it and potentially minimize it over time. A couple of tips that I think work pretty well. First, I know as a clinician, it can be sometimes overwhelming or anxiety provoking to hear that somebody you're working with is thinking about death or suicide or wanting to harm themselves. So sometimes our anxiety rises and it makes it hard to just be with a client who's in a lot of distress. So I always try to really remember that suicidal thoughts, for example, these are an expression of pain. This is a client who is really suffering and feeling like this is the only way to cope with the feelings that they have. I try to model that sort of non-judgment for clients because I have found a lot of clients have significant judgment around these thoughts. Maybe it's from their kind of cultural or religious background, that sort of suicide is wrong or bad or evil or sort of sinful. But also, just they have potentially expressed these thoughts to people before and have received invalidating responses, and therefore also, again, are potentially very self-critical about having these thoughts. So, I really try to kind of talk about it as like, okay, like look at, this is clearly where, sort of your pain level today is very high. If this is kind of where your mind is going, that the only way to feel better is to not be here or to hurt yourself. And that I think sometimes just sort of connects people, you and your client together to kind of back on the same side. I think sometimes it can be really hard when somebody's expressing suicidal thoughts, for example, we have to do some risk assessment, but sometimes that risk assessment can sort of push a client away or even lead to this sort of like cat and mouse sort of like seeking out of like, well, wait, where are you on the sort of risk scale? So always just coming back to like, okay, we're on the same side here. I understand this is an expression of pain. And related to that, I really try to get to a place where my clients share in that responsibility of reporting risk when it's needed. So talking about ways to kind of, or sort of thresholds, to sort of where they might be, or I would want them to be saying to me, hey, I'm thinking a lot about death this week, and to the point where like, it's been a while, but I started to think about, what would I do if I wanted to, harm myself. So trying to make that not just your responsibility as the therapist, but, and sort of inviting the client to share in that too. And part of that goes back to that previous bullet point, making this a safe space where they feel understood so that they are then safe to report when they're having thoughts, especially before they get really high. I think this also, sometimes when somebody's chronically suicidal, we can get into this, or self-harming, we can get into this pattern of like every single session having to spend 15, 20 minutes doing a risk assessment, documenting various behaviors, and that can be therapy interfering. It takes up a lot of time, and it can be sort of strangely almost reinforcing of the behavior, like, oh yes, like this is what we talk about in therapy, so therefore, like, I'm going to sort of spend a lot of time thinking about this through the week. So again, chronic self-injury, chronic self-harm, developing some comfort as a therapist that people are going to be passively suicidal, potentially quite a bit. And then trying to kind of understand from the clients, with the client's help, when is it rising to a level of like, okay, we need to talk about this now. It's hard to say exactly what that looks like, except that, again, if you've been having lots of conversations kind of early on about this, hopefully you start to get a sense for sort of what this looks like for the client. And I'm happy to sort of answer more questions about that at the end too. But to start to wind down a little bit here, so establishing expectations early on in treatment, I think, is really important. So I've put on this slide some of the discussion points that I really try to make space for in those first couple months of working with somebody. So this might include things like diagnostic feedback, to help clients have a frame from which to understand their symptoms and why their symptoms have been lasting for so long, which rolls into that second point of the biosocial model too, helping people to really understand sort of why they're experiencing what they're experiencing. I talk very carefully about my rationale for the treatment plan, including if I am making recommendations to add on certain forms of therapy, why I'm making those recommendations, how I think they could support the treatment plan. Linking your treatment approach back to the case conceptualization or diagnosis. Clarifying those communication boundaries and any other boundaries that feel relevant. As well as your risk management protocols. So sort of saying like, okay, I know you're sort of chronically suicidal. These are the things I really want us to look out for. It's when you are kind of becoming, particularly signs of more active suicidal risk. And this last one, so important, a reminder that treatment gains take time. And so urging patience for the client, that really just because they're not seeing that they're getting better right away doesn't mean that this treatment isn't working for them. And certainly noting things that maybe small things that are actually helping them, or that they're making gains in certain areas. I really like to point those out when they happen, but also remembering that the sort of arc of treatment is just a lot longer when there's chronic emotion dysregulation. So from my perspective, I think as clinicians, this can be difficult work, that it's really satisfying. We can have someone come in and say, I feel, depressed or anxious. And then, 6 months later, they're living, a much happier existence. This is often a population where that's not possible, but still I find that it can be really rewarding when you're approaching it with this kind of deliberate care and rationale as I'm talking about. So offer patience to yourself and your client, that the pace is often slower in this sort of presentation. I didn't talk much about therapeutic alliance because I think you could probably have a whole other presentation on this, but attending to that relationship building early on is so important. Trust, unconditional positive regard. It can take a lot of time to build, but ultimately intend to, there can be often a lot of sort of ruptures throughout therapy. But this is a really powerful agent of change, both in DBT and TFP, for example. There's a lot of thought about this. So in the end, the payoff can be life-changing for both the therapist and client, again, with a lot of these sort of important components to the treatment frame in mind. And that's everything that I have for the presentation portion here. So thank you, everybody, for sort of listening to my points here. I think I will leave the presentation here for now, and then I'm going to